I'm James Malatak. I'm one of the hospitalists here, and then I also help with patient blood management, so kind of knowing when to use blood, and then also kind of the bloodless. And I think, we all talk about, transfusing patients at a level of hemoglobin of less than 7. I kind of just want to talk about a little bit about why we choose, why we do what we do, and where the evidence comes from, and how to kind of manage anemia a little bit better than maybe we initially were before this lecture. So we're going to focus on these are the objectives of knowing when to transfuse a patient in septic shock or in the ICU, knowing when to use blood transfusion or packed red blood transfusion in acute coronary syndrome. How about in a stable upper GI patient, and then after hip surgery. And then we'll like to talk about kind of the complications of packed red blood cells, and when we give blood, what does that potentially lead to? And then finally understanding the natural history of what if we don't fix anemia? What happens, and when do bad things happen? So I used to do this talk in a lecture hall, and I could ask you guys questions and you guys would answer. It's a little bit more difficult, so I can answer them myself. So let's just jump right in. You're an ICU intern and you're doing well. Everybody has nice things to say to you, but tonight is your first night on call in the ICU, so you're a little apprehensive. Your pager goes off and you return the call, and it's Mr. Smith, who's a 70-year-old male with BPH, and he presented with septic shock secondary to E. coli UTI. Mr. Smith required 3 liters of LR in the ER and coming up to the ICU, and then he was just started on Levophed a couple hours ago to maintain his blood pressure. His evening labs show that his hemoglobin dropped from 11 to 9, and that his acute kidney injury is resolving. The nurse is concerned about the hemoglobin has dropped, and she wants to know if we should transfuse the patient, and what should you do? And so we'll talk a little bit about why this question, I guess it was more pertinent when we used to transfuse to get a hematocrit over 30 because of the Rivers trial, the early intervention trial in people with sepsis, and we'll talk a little bit about that more. But let's talk a little bit about septic shock and transfusions, right? So there was a trial called the TRIST trial that came out in 2014 that looked at transfusions in patients with septic shock in ICU patients, right? And it basically it was multi-centered. It was over 1,000 patients. And they looked at transfusion triggers of less than 7 or less than 9. And they looked to see how the patients did. And so here is their survival curves, right? So first of all, you can see that sepsis is really bad, right? 60% of the patients not doing well 90 days out, right? So the first, I think, takeaway is that sepsis leads to a lot of death in your patients. And I guess if you've been a resident for a while now, you know that this is a lot of times the way our patients die. But also, it didn't matter whether we gave them blood, which is the higher hemoglobin threshold, so transfuse them higher to 9, or if we just shut up for kind of what we've been doing, the 7. And a lot of this is because of this, right? We can see that the patients don't do any better if you keep their hemoglobin higher. So that kind of tells us that, well, while we might not be hurting or not by helping them by giving them blood transfusions, another question is, are we actually hurting our patients by giving them blood transfusions? And so there's another trial, actually 15 years earlier, called the TRICK trial, that actually looked at blood transfusions in critical care patients. And it looked at 800 ICU patients, and they were again randomized into a restrictive group, so between keeping the hemoglobin between 7 and 9, or a liberal group, getting up to about 10 and 12. And everyone, the farther I get out from when I wrote this, it seems like everyone thinks it's crazy to keep the hemoglobin from 10 to 12. But this was something that was done, not that long ago, and it was because we didn't know. And these are the trials that kind of told us we don't need to be giving blood all that time. So what they found in the TRICK trial is that at 30 days, there was no transfusion benefit in the liberal group. So the ones that got more transfusions, they didn't survive anymore. And the p-value, again, this was non-inferior. So kind of a lot of what we saw in the septic shock, the TRIST trial, it was also reproducible in the TRICK trial, which was not just shock. And right, these patients don't die as much because these don't all have sepsis. These are other reasons that they're in the ICU. Right, their mortality is 80%. We saw the or sorry, their survival was 80%. And we looked at the sepsis patients, their survival was 60% 90 days out. But if we even broke it down a little bit farther and said that there was no difference between the two groups, but if you actually looked at healthier patients, so like people with Apache scores of less than 20, and Apache 2 score is a way to decide how sick a patient is. And then you actually found that there was some benefit in restricting the amount of transfusions in those patients. They lived longer when they were not as sick, unless if you gave them blood transfusion, the thought was it may have made them sicker. Or at least they certainly correlatedly passed away more often. And then the same thing with younger patients, right? So if you gave blood to someone who was less than 55 years old, there was actually a statistically significant reduction in their survival. You can see right here. And so my takeaway is that if the healthier the patient is and the less sick they are, the worse idea it is to transfuse them. That maybe when someone is very sick, that blood might be something that can you might be able to use and doesn't make them any sicker. But if they're young and not as sick, that giving them blood transfusions may lead to worse outcomes. So why is that? So when you looked at what happened to these patients is that, the patients who got more blood, right? So right here, the liberal group right here, they had more myocardial infarctions. They had more pulmonary edema, right? So like Taco, we're giving them volume and they end up getting pulmonary edema, flash pulmonary edema. We see that all the time in giving patients fluids or blood or albumin. And they also developed more ARDS down here, right? Not statistically significant, but certainly a trend. And so, and this is probably more like your trolley that you see after blood, like transfusion-associated lung injury, right? And so giving blood, just like giving fluids, is not a benign thing, that you can have potential complications to your patients. And so if you don't need blood, it's really not something you should be given. And so we kind of now know that most of our patients in the ICU, we want to shoot for a hemoglobin level of 7. So would our answers change if we said that Mr. Smith's hemoglobin when he got admitted was 8.5, got his 3 liters, and it dropped to 6.5? The current guidelines for surviving sepsis say that we want to shoot for a hemoglobin level of 7 in people who are septic. The data is just not there for hemoglobins less than 7. And this goes against what I said, this Rivers trial, which is this early intervention. That's why we give lots of fluid and give antibiotics. We used to check to see if their hemoglobin was low, and if it was, or their hematocrit was less than 30, we would give them blood transfusions. And now that's really been kind of thought that this is not a good idea to do. And so things keep changing, and I suspect that someone will eventually do a trial looking at hemoglobin of 7 versus 6.5, and then our new goal is going to be 6.5. And so I think, right now we use 7 in the ICU, but I think that will probably change in the future as we get more and more studies. So the key points in at least sepsis or ICU patients is septic patients, ICU patients in general should have a hemoglobin of 7 based on our guidelines, okay? At this point, there's no studies to show the outcomes of hemoglobins less than 7 versus hemoglobin greater than 7. I think that trial needs to be done. And then ICU patients who receive transfusions liberally have worse outcomes than patients who do not, right? And we think it's probably from all of the potential complications like the MIs and the demand is the ARDS and volume that they end up getting. Okay, let's keep moving forward here. So Mr. Smith's niece calls you to fill you in on some more medical history. He lets you know that Mr. Smith, who's had a cardiac catheterization in the past 2 years ago and was diagnosed with some 2-vessel coronary disease. He's been treated medically. The nurse calls you again and asks if you want to transfuse Mr. Smith because she used to work in the CCU and used to use hemoglobin of 10 in cardiac patients as a goal. She mentions that Mr. Smith is also having chest pain. So you're a great intern. You go run and see Mr. Smith and you assess him and you see that his high sensitivity troponin is 650. He has an EKG with ST depressions in lead 2, 3, and AVF. And you're very concerned, appropriately so, about acute coronary syndrome. So, and given his hemoglobin of 9, do you want to transfuse him? So a similar case happened to me when I was in residency where I had a patient who was having acute coronary syndrome. His hemoglobin, I think, was 9 or 8.5. and he was having chest pain despite being on the appropriate medical management. And I called the fellow, who was a first-year fellow at the time, and said, "Hey, what do you want me to do with this guy?" And he said, "You better get his hemoglobin past 10." And then after 2 years of more residency, I had a very similar patient. I called the same fellow who is now a third year of cardiology fellowship. And I said, "Hey, I'm going to transfuse him up to 10." And he said, "Don't do that, right? Because that's not necessarily something we do anymore." So this stuff is changing all the time. And in fact, I think we can even talk a little bit, we're going to talk a couple about studies. I think I could actually change my mind even more so now. There's been, and the reason why we start thinking about transfusion these patients, there was big observational analysis looking into 3 large ACS trials. These are Gusto, Paragon, Pursuit. These were huge trials, and we added them all together and looked at 24,000 patients. This is just an observational postdoc. This was looking at other things in ACS, but people put them together, and they found that people died a lot more, right? This is a transfusion group, and this is mortality. They died much more frequently, about 8% of the time, versus only 3% of the time who didn't get transfusions. Now, again, this again is just a correlation, right? This is not a randomized controlled trial. This is just observational. And people who are sicker, they get more blood, right? We transfuse those patients because they're bleeding, because they're, whatever the reason is. Patients who are sicker definitely get more blood. And so is this just a correlation, or is it actually the transfusions are causing problems? So there's been a couple small studies. This one was a 45-patient, multi-center randomized trial. And they looked at patients who had hematocrits less than 30 and were having ACS. And they put them into a group where they transfused them to hematocrits of 30 and 33, like the hemoglobin of 10 that we talked about. And then a conservative, basically keeping it above between 8 and 9, or hematocrit of 24 and 27. And so in this study, 100 of these patients got 2.5 units per hospital stay. And this one's about half of them got transfused, and they got the ones that did got about 1.6. And they looked at in-hospital death, recurrent MIs, and worsening CHF. And actually, this study was some of the patients were at hospital center and the Washington, D.C. VA. And so what they found is in the patients who got liberal, so they got lots of, more blood transfusion, higher hemoglobin goal, there was significantly more death, right? 38% versus 3 with a p-value of 0.46. There was more heart failure, right? If you're overloading them with volume, and that was statistically significant in the liberal group. And then there was also more death and more myocardial infarction at 30 days out. And so that kind of tells you, well, maybe we shouldn't be shooting for a hemoglobin goal of 10. But there was another study done around the same time that was a little bit bigger. And again, it was a randomized control trial. Looked at 110 patients with ACS and stable angina or getting cathed with hemoglobins of less than 10. And they put them again in a basically the same study. They gave them a liberal group was 10, and then the conservative was greater than 8. And they got a little bit less blood than the other group. But the same kind of outcomes. And this was actually the opposite, right? So there was actually no difference between the two groups statistically, but there was a trend for more death in the lower hemoglobin group. And so, and if you actually parsed it out and just looked at death, there was a potential statistically significant change between these two. These are all outcomes. So this is death, MI, or revascularization. And so this kind of went against of what the prior study had shown. So there actually is some debate, and I don't know if you guys have noticed, about what we should do with patients who are having acute coronary syndrome. So the ACP in 2013 basically said they recommended a trigger threshold in patients with heart disease for 7 or 8. But again, they gave this a weak recommendation because there's not really good evidence. And so the data is confusing. We need the current guidelines, like the American College of Cardiology recommends 8 for patients in ACS. But when I talk to different cardiologists, because it is confusing, they all kind of tell me a little bit different. They're basically say if they've kind of maxed out all their anti-anginals and they're still having chest pain, then they'll add on another blood transfusion, even if their hemoglobin's above 8. And so it's not definitively known, except now there's actually a study that actually, when I was prepping for this in January of 2021, there was this reality trial where they looked at restrictive versus liberal blood transfusions in patients with acute myocardial infarction and anemia. So this one was actually larger, right? So it's like 6 times larger than that, the biggest one that was 110. So it looked at 668 patients, and it was in France and Spain, 35 different centers. And they put these patients who are having myocardial infarctions and anemia with hemoglobins between 10 and 7. They got into the trial. And they were randomly allocated to either be in a restrictive transfusion strategy, so keeping their hemoglobin above 8, versus liberal, getting it above 10. And then their primary endpoint was major adverse cardiac events, right? So and death. And so there's only been 30 days that they put out the data, so more data will come in as we move along. But basically, the primary outcome shows that there was no inferiority in the 8 versus 10 trial. So this is the 8. There was less death, but it wasn't statistically significant, but it was statistically non-inferior. So there was no difference. There was, as far as death, so this one up here is all primary outcomes. So MACE and death, reinfarction, stroke, needing revascularization, there was no difference between the two. But if you looked at just death, there was statistically significant in the group that was more conservative. 5.6 of them died versus 7.7 in the ones that got more blood or shot for hemoglobin greater than 10. There was more infection in the group that got more blood, and there was more lung injury statistically significant in the ones that got more blood. So it kind of makes you say, I mean, we'll see what this final trial, it's going on right now, and see, I'm sure they'll add more patients, but it makes you kind of think that 8 is probably the appropriate goal in someone who's having acute coronary syndrome as opposed to 7. But again, we haven't really looked at 8 versus 7. So I think that study needs to be done. But for now, you can be pretty clear that acute coronary syndrome, you should probably just transfuse up to about 8 and then stop. All right, we'll keep moving on. So poor Mr. Smith, while he was evaluating Mr. Smith, so this is actually his roommate. His roommate has cirrhosis, and he has esophageal varices, and he has an episode of melanoma while you're in there. You check his hemoglobin, which is now 7.8, down from 9. He's hemodynamically, the patient is stable. You call GI and ask them for scope. Should you transfuse this patient, and what is your hemoglobin goal? Right, so you do all the good things that a normal intern should do. You get 2 good IVs, maybe he has a central line. You start treating him with octreotide, you give him some PPI, you give him some fluid while you're waiting for GI to come in. But if he's hemodynamically stable, so this is for all hemodynamically stable. If they're not hemodynamically stable, you give that guy blood, or if they're really hemorrhaging, you give them blood. But in patients that are just stably bleeding, there is a trial from 2013 that looked at transfusion strategies for acute upper GI bleeding. And so it looked at 921 patients, and they basically put them into 2 randomized control. It's a randomized control trial. They put them into 2 groups. One that was to keep the hemoglobin above 7, and one that was to keep the hemoglobin above 9. And these guys got about 2 more units of blood compared to the hemoglobin of 1.7. So significantly more blood. All right. And so what they found was that actually the patients who, and the first thing I want to take you notice is that the death rate at 45 days, right, is in the 90s for both of these. Or sorry, the survival is in the 90s. As opposed to the sepsis, which again is a bigger deal when the survival was in the 60s, and the other ICU players, I think all players come together in that critical care, it was like in the 80s. So again, GI bleed is bad. It's not as bad as sepsis. So just so you guys know, sepsis is something that really hurts our patients. But if we look at these 2 groups, you can see that the restrictive strategy was the way to go. And this was really driven by the cirrhotics. The Child-Pugh A and B in here did much better than they did in here, who got more blood. And the thought was that the more blood you give these cirrhotics, is the more volume they get in their portal system, and can cause them to have a stable clot destabilize and rebleed. And so there was more complications in this group too. So they had more acute coronary syndrome, they had more pulmonary edema, they had more transfusion reactions. And there were a couple patients, actually the same amount, 8 in the restrictive and 8 and 6 in the liberal, that had to be removed because they went into like hemodynamically unstable situations. And so then they just got a whole bunch of blood. And so they were pulled out of the trial. So patients with upper GI bleed, the goal of their hemoglobin is greater than 7. And then the patients who most benefited from having a lower threshold compared to 9 were the ones that were cirrhotic, Child-Pugh A and B. Again, this is not something to think about in someone who is hemodynamically unstable or having severe acute bleed. If that's happening, you give those guys blood and you stabilize them. And then once they may be stabilized and are just oozing, then you might shoot for more of a hemoglobin goal of 7. All right, back to Mr. Smith. So he unfortunately is on the men, and unfortunately, in his eagerness to be discharged, he falls while transferring to the commode. He breaks his right hip. He's taken to the OR and his hip is pinned. 4 more days, and he is now ready for acute rehab. His hemoglobin is 8.2, and ortho wants you to give him a transfusion to tank him up, which is, a lot of people say this, let's just tank him up so he can participate in AR. And you recommend against it. The ortho resident, he kind of pushes you and he says he wants to know why. So you can actually talk about this FOCUS trial, which actually looked at liberal or restrictive transfusions in high-risk patients after hip surgery. So this was a randomized controlled trial of 2,000 patients that were older than 50. They had a hip fracture. They were anemic with hemoglobins less than 10. And they either had coronary disease or risk factors for coronary disease. And they were placed into 2 groups, a liberal group and a restrictive group, which was they got transfusion when they got less than 8 versus less than 10. So the primary outcomes were the ability to ambulate across the room at 60 days and then also death. And there was no difference between these 2 groups. And so, like we said, you can certainly have more complications in the with giving more blood transfusions. We've kind of shown that a couple times here today. So I wish they would have done a hemoglobin of 7, but they chose 8 in this study. And so right now we're kind of stuck because I don't think there's been another study done kind of transfuse these hip patients to 8, as that seems to be the most beneficial for them. Okay, so when you consent someone for a blood transfusion, usually what I say is you have a risk for a potential infection, whether that's a bacterial infection or a viral infection like HIV or hepatitis B or C. I tell them that you may have an allergic response to the infusion, or it might be harder for you to get blood transfusions in the future because you get alloimmunization. And that's usually all I say when I talk about a blood transfusion, because there are a whole lot of risks that are pretty uncommon, but there are lots of risks. So if you look, and when you transfuse somebody, about 1 out of 100 get either allergic response, or they can develop alloimmunization, or TACO, which is the transfusion-associated cardiac overload, right? So they get volume overloaded. And about 1 in 5,000 to 15,000, you get TRALI. Sometimes you get a hemolytic reaction. And then occasionally, even though all of our guards, you do occasionally sometimes give them the wrong unit, right? They might have some mismatch. And then these viruses, they are pretty uncommon, right? Hep B, 1 in 2,000, 1 in 2 million for Hep C and HIV. But that does happen, right? About 7.5 times someone gets hepatitis C from a blood transfusion in America, or HIV in America each year. And so every time you give them a blood transfusion, you're signing people up to get a chance at one of these, to roll the dice, right? And even if it is rare, this does happen. And I certainly have given a lot of transfusions in my day, and so you will see some of these. So I think it's very important to try to find time when you can actually limit your ability to, your limit when you have to give someone a blood transfusion. Other things that can sometimes happen with blood transfusions, it does seem that there's an increase in the nosocomial infections in patients who are critically ill. Right, so this is a study from, I think, St. John's Mercy Medical School or Medical Center. And it looked at, it was just observational, it was prospective, but it looked at 2,000 patients who were both surgery and ICU patients, surgical and medical ICU patients. And they looked at who got nosocomial infections. And if you had gotten a nosocomial infection before a transfusion, you were placed in the non-transfusion cohort. And then they just looked at how many infections they got. And you can see overall about 7.5% of patients got nosocomial infections. And if they were transfused, it bumped up to 14.3. And if you weren't transfused, you only got about 5.8% chance. And so, again, this again is just a correlation. It's not saying that blood necessarily causes you to get an infection, but it shows that you're sicker, and the sicker you are, the more likely you are to get nosocomial infections. However, it does make you wonder that maybe there is something that's happening when you give someone blood that puts them at risk, right? So what if we don't transfuse a patient, right? So if you look at historical data about Jehovah's Witnesses who refuse blood transfusions because of religious reasons, and there was a study that looked at basically 61 reports of looking at 134 patients, and they ended up having 50 deaths. And these were all witnesses with hemoglobins less than 8. They've said when they looked at it, about 23 of them were primarily due to anemia. And except for 3 that were post-heart surgery, all the anemias happened when the hemoglobin was less than 5. But it was almost like a coin flip, right? So 25 people survived with hemoglobins less than 5. And actually on M43, we had a lady who came in with Menometra Raja. Her hemoglobin was 4.6. She got blood and iron and actually did fine. And it's not like just because they're less than 5, that means that they're going to die. It's just you're at higher risk for dying, right? So I think, you know, as we move forward, maybe this is going to be closer, or we're going to get closer to this hemoglobin of 5 as a transfusion threshold. Okay, so just kind of wrapping up our objectives, and then I can take some questions. But you know, when patients who have septic shock or upper GI bleed, our goal hemoglobin seems to be to transfuse to get greater than 7. And then patients with hip surgery, because there's been no study looking at 7, they chose 8, as well as acute coronary syndrome, where I think it seems like the goal hemoglobin of 8 seems pretty well established, or it seems to be moving towards establishment. We didn't talk about cardiac surgery, but our goal for those are 8. And then I think this is an important one because I see this a lot when patients get admitted to the hospital with a hemoglobin of like 6.4. They get a transfusion, which isn't necessarily wrong, but there's been no workup done for why they're anemic. And the other thing is, if a patient doesn't need a blood transfusion, right? So just because your hemoglobin drops below 7 doesn't mean you need a blood transfusion. You can take some time, you can try to figure out why their hemoglobin is low. And if it's iron deficiency, if it's B12 deficiency, is it because they have something else going on? You can figure it out and you can treat that cause, and you can avoid giving a blood transfusion. And all of these, right, risks and nosocomial infections and worse outcomes, you can avoid doing that to your patient. And so I think we too many times reflex to giving someone blood just because their hemoglobin dropped less than 7. You can try to figure out what's going on and try to treat that cause moving forward. And so I think that's what I challenge you guys to do, is try to figure out the cause of why someone's anemic before just reflexively giving them blood. And we talked about understanding the complications of packed red blood cells, right? So we talked about this increased mortality, nosocomial infection, as well as longer stays. And then also, based on a natural history of severe anemia, like the JW population, a hemoglobin of less than 5 may eventually end up being our inflection point for risk benefit of PRVC transfusion, or maybe a little bit higher. I don't know. Well, that will have to be told. But I imagine that the longer I give this talk, the more I'm going to have to change these hemoglobin goals of 7 to lower. So these are my sources.